Thank you for joining us on Give It a Name with Jenny Lynn. Today we are making pancakes. Believe it or not, we're going to be having some fun with you while we make our breakfast pancakes. And I want you to know that this is not true. After leaving the doctor's office after a mammogram, you do not look like this. Today, I'm going to, I have the privilege of speaking with Dr. Cowan and Jenna Hessman, both of the radiology department at the Palo Alto Medical Foundation, and they are going to answer some of the questions that we all have about mammograms. I'm going to begin by introducing Dr. Cowan. Dr. Cowan, would you like to tell us a little bit about yourself?
Sure. Well, Jalen, thanks for having us both here on the show. We always enjoy the opportunity to talk about this. It's something that we feel is very important. I'm a physician, a radiologist who interprets images, CTs, CAT scans, X-rays, and mammograms. I also do biopsies where we use radiology studies to identify abnormal areas inside the body and to direct a needle to that area to get tissue samples. I've had about 10 years of training for this, and that includes some specialty training in breast imaging.
Awesome. And Jenna, I'm going to share a little bit about you and I. We have a little bit of a history before I ask you to introduce yourself. I was your patient a year ago after having had a breast cancer threat myself. I had come in for my follow-up mammogram and was very nervous. And when you came to get me, I remember saying to you, "Finally, you're coming to get me so we can make breakfast." Do you remember this?
I do remember, Jenny, and to be honest with you, I thought that was a very enlightening and delightful comment. I've done mammography imaging for several years, and no one has ever come and told me that we're going to make breakfast. And I have to admit, it took me a second or two to figure out that you were referring to pancakes, and it was completely delightful.
Well,
Wonderful experience.
Well, thank you, and I was glad the way you responded because I was very nervous. I didn't know what my test would reveal, and so I was trying to make myself comfortable by throwing that out there and hoping to get the reaction I got from you. And you were perfect. And I remember saying to you, I'm going to start my own television show, and I want to do a show about mammograms and highlight the fun side of this, because I really believe there's a bright side to everything. So would you like to share a little bit about yourself and why you're such an optimistic mammographer?
Sure. Well, it's interesting because I really enjoy doing mammography and breast imaging. There's so many times that patients come through our doors and they look at the mammographer and they say, "How can you do this type of work all day long, every day?" And to be honest with you, patients don't understand there's a lot of diversity with mammography and breast imaging. Even though we're doing some of the same views time and time again, we're seeing different patients, we're seeing different personalities, and one thing I really enjoy about mammography is just the sheer fact that you get to know the patient. There's a real sensitivity side that's needed when doing mammography, so it kind of gives the mammographer, the technologist, an opportunity to address a little bit of the emotional aspect as well. And to be, uplifting and well-spirited, I think that's a wonderful part of care that you can give the patient in kind of an awkward position. Because we will state that, mammography is hands-on, and from what you read out there in the media, a lot of patients just think, oh, I have to go see a stranger who gets to, press my breast today. And we really want it to be more than that. We want you to walk away knowing that this is a warm and caring experience.
Great. So, Dr. Cohen, I have a question for you, because a lot of people lately are wondering, because we hear about MRIs and ultrasounds, and could you tell us why someone should have a mammogram versus an ultrasound or an MRI?
Well, sure. I mean, the main reason certainly is that mammography is the only proven screening test that will reduce deaths from breast cancer. So a mammogram itself are two pictures of each breast that we use a very tiny dose of X-ray radiation to give us those images. Ultrasound and MRI are used for breast imaging. Most often, though, they're used to address a possible abnormality that we see on the mammogram to give us further information that the mammogram's not.
Okay. And Jenna, I was going to ask you this question. How should someone prepare for a mammogram? And why is it you tell patients not to use powder or deodorant when they're coming in for this procedure?
Okay. Some of the best preparation in regards to mammography is, for one, scheduling can be a very important aspect, because for those premenopausal women who experience some breast tenderness, to schedule the appointment at a time when your breasts are less tender is recommended. And normally that time does fall, after the menstrual cycle is completed. So that's a very important factor. Another way a person can prepare is, if they're coming to the facility for the first time, and if they know where the outside mammograms are, it's nice to have those with you, or at least have the information to give the Department of Imaging, so in case we need those for future use, we can try to track those down. So those are a couple of important aspects. One of the things that I would love to see patients come in to the exam room and do is just to be able to relax. Like I said, I don't want to be a stranger, working on them. I want them to relax. I want them also to communicate with me if they are fearful of this procedure. So oftentimes women come in and they just stay very, very quiet, and they're afraid to let you know that they are scared. And there's also patients that have come in and they have, had an experience 4 or 5 years ago that was not a good experience, and it's kind of held them back from coming in for annual or routine examinations. So if they can just let us know how they're feeling, that is some of the best ways that we can be prepared to help them ease through this exam.
And that's one of the reasons why I wanted to do this show, because a lot of what you've said is true. People are afraid. You hear that you get your breasts squished flat like pancakes, and they're very painful. And so, they're hesitant because of the fear, but it's something that you cannot allow fear to get in the way of, right?
Sure. And Jenny, to be honest with you, most women do not smash down like a pancake. So I will let you know. Those pancakes are pretty much a rare exception, and there's some patients that, can be in their 80s and their breasts get very soft and very pliable. For the most part, women should not be afraid that they're going to be compressed down to a pancake.
And you're trying not to press it as much as possible. You just want to press it well enough so we get a good image, right?
We just need to press it well enough so it's tight.
Okay.
A little bit firm. And also with compression, it doesn't always have to be all at once. Usually a lot of mammographers will compress down about half the way. We'll make a final positioning adjustment, and then we'll compress a little more if the patients can tolerate it.
Okay.
And we should ask them how they're doing. They should never feel like they just have to stand there and just let this machine compress them to the point that they're in excruciating pain, because that is not the goal of mammography.
Okay, great. That's good to know. So, Dr. Cohen, what can women do to prevent their risks of developing breast cancer?
Well, truly, the main risks for a woman for breast cancer, one is just the older you are, the more likely of developing breast cancer. And a lot of it has to do with the amount of time estrogen is affecting the breast tissue. So the other factor, just being a woman, makes them much more likely to get breast cancer than, say, a man, about 100 times more likely. But so the things that a woman can control, their lifestyle choices or lifestyle options that affect a woman's risk for breast cancer. We certainly know that obesity can increase the risk for breast cancer. A lot of it all kind of plays back on how much estrogen is affecting the breast tissue. The more fat there is in the body, the more estrogen that can affect possibly small cancers in the breast and drive those cancers to get larger. A lot of times we see this more commonly affecting women after menopause than before menopause.
Okay.
So just being active can reduce your risk for breast cancer. One of the latest recommendations is really intentionally going out and exercising half hour to 45 minutes a day, maybe 5 days a week. It's more than the half hour 3 times a week, but all this does decrease your risk from breast cancer.
It doesn't matter what you do. It always comes back to exercise. You cannot go wrong with
diet.
exercise,
Yeah,
right?
And a little bit of alcohol reduction as well.
Yeah.
Yes.
Really? Alcohol helps, is what you're saying?
No alcohol.
Actually, the more you drink, the higher your risk. They'll even say that one drink can increase your risk about 1.5 times over a woman who doesn't drink at all. Now, you would also say that there are some benefits to one drink a day for other cardiovascular reasons, things like that.
Yeah.
But just to know, if a person's interested in lowering their risk as much as possible, it would be, have a normal weight, exercise often, Amy, and don't drink alcohol.
Well, you and the cardiologist are here. You're in conflict here because I guess you need to decide if you have a family history of breast cancer. Then you have to ignore the cardiologist. But if you have
Everything is a risk and a benefit. I mean,
exactly. So anyway, Jenna, can someone have a mammogram if they're pregnant?
Typically for screening mammography, it is not recommended. We all know that there's certain times that certain indications may lead to having maybe a diagnostic mammogram if the patient, has come across a lump or, some kind of concern in the breast. But typically, pregnant women, their breasts are under constant change. And Dr. Cowan, you can maybe give a little input on there.
right. Certainly just in this day and age, women are older now. There are more women who are older that are having children. So there's a lot of people that are pregnant at, in their early 40s, where a lot of groups would say mammography should start. The things that happen as far as for pregnancies, it can increase the density of the breast tissue. It just makes that more difficult to see things inside the breast that we're looking for. And it's kind of a risk-benefit sort of equation that we're always looking at, whereas why don't we, wait another year, have the baby, breastfeed, and then after that, get back to just screening where we're just looking for something where the woman doesn't have any symptoms. But if there's something that she's concerned about in her breast, then we're going to need to do, some sort of study to figure out what's going on. We wouldn't want to wait on that.
Okay. So what is the smallest size tumor that you've ever found on a mammogram?
Well, truly one of the main goals of mammography is even to catch cancer before it's a tumor, before it's a mass. A lot of what we're looking for on mammograms are tiny little grain-like areas of sand called calcifications, which can be the earliest form of breast cancer, where it's forming inside the milk ducts. Now, there's lots of benign causes for these sorts of calcifications too, and it's up to us and our training to try to figure out the difference. And a lot of times we get to a certain point where we can't tell the difference, where we'll need to do a biopsy to see what's going on. So in those cases, we'll have biopsies of just several millimeters of some very low-grade cancer within the ducts called DCIS. Certainly, the denser breast tissue is, and the more, if we look at a mammogram here, the more white, the more glandular tissue and fibrous tissue in the breast, it makes it harder to pick up the masses which have the same sort of whiteness. And if there's a lot of that glandular tissue up against a mass, we may not discriminate the edges of a tumor. So if there's a very fatty breast, which looks very dark on a mammogram, we could see a tiny 3-4 millimeter little cancer. And our whole goal is to pick up these cancers as small as possible. If there's a cancer that's a centimeter or less, it's very unlikely for that cancer to have sent cells elsewhere in your body. And that the main goal is to pick up a cancer before it's sending cells elsewhere in your body, because that's going to essentially that's going to be the thing that can affect your lifespan.
Wow. So I have read a surprising number of men have had breast cancer. I was just in shock, because you just assume, because you don't see men with breasts like we do, that they can't have breast cancer, but they can. How have you ever seen, or have you had patients who've had male patients with breast cancer?
I certainly have. It's very uncommon, but it's, as I said before, it's about 100 times less likely, but it happens. About, in this country, over 200,000 women had breast cancer last year. Well, just under 2,000 men had breast cancer. And so it's important for men to realize they can get breast cancer, so they don't ignore. We're always telling women not to ignore a lump in their breast. Well, a man should not ignore a lump either. Now, there's the main cause for a man to get a painful lump in their breast just under the nipple is often from a condition called gynecomastia, where it's a proliferation of glandular tissue.
Okay.
And that's common in older men, particularly men who are taking certain medications, either or being treated for prostate cancer. But it can happen in young men as well.
Okay.
A lot of times, it's maybe the young men taking anabolic steroids. Marijuana use can lead to gynecomastia. And so, our job there at that point is to try to discriminate between the two. So men are most commonly coming to us because of a lump that turns out to be gynecomastia, but it can be breast cancer. And a lot of times the surgeon that is maybe referring the patient to us, we'll still sample that tissue just to make sure it's not cancer, but it does happen. Now, the outcomes are still similar for women. Often, men aren't getting the cancer that we're detecting inside the ducts because often they don't have those milk ducts ahead of time. But, so when they get cancer, they're getting a mass, but their outcomes are still about the same depending on the size and whether the cancer's gone to lymph nodes elsewhere in their body.
And it can also spread from another part of their bodies to their breasts.
Well, so it's really unusual for a cancer to be elsewhere that goes then to someone's breast. There are some some cancers that can affect the lymph system of your whole body, say like lymphoma or something like that, where there can be cells that go to the breast. But again, most often if we see a mass that's in the breast, it's the assumption that it's breast cancer. It's coming from the breast.
Because with women, we're told past a certain age we need to go in for a mammogram. And this is not true for men. I mean, until recently, well, I shouldn't say that, but I'm saying from my understanding, this wasn't true for men. Because as far as I know, the medical community has always geared their studies and everything, all their reports toward women. And so when I heard that we've had men with breast cancer, I was just like blown away. And now that I'm aware of it, if a man does not find a lump that makes him suspicious, then you don't just screen a man for breast cancer.
No, we don't.
So I guess this is why if you find a lump in your breast, gentlemen, please call up the mammography clinic and schedule an appointment, because we are guaranteed that this is not what's going to happen to you when you go in. So pick up the phone if you find anything that resembles any of the symptoms that are being described by Dr. Cowan, and schedule an appointment so you can have the necessary studies done. And
make sure you tell us it's in the breast.
And make sure you tell them it's in the breast.
That's right.
And so since we've been focusing on more of the serious aspects of this, I'm going to get back to a few more of the serious questions in a little bit. But how about if, Jenna, you share some of the fun experiences you've had, things that were funny that you experienced while doing mammography?
Sure. Well, when I first started out as a mammographer, I was brand new, and I was working in a little building that had one mammo room, and there was nobody else around. And lo and behold, I get my first male patient. You talk about men and lumps and breast cancer.
Really?
So this 17-year-old walked into the department, and I was like, okay, here's my first male patient. And I have him take his shirt off, and literally he has the washboard chest, stomach, not an ounce of fat on him. And so it was quite hilarious, myself trying to get mammogram images on him. Normally we don't have any problems with men, but in this case it was one of my most treasured moments early on in my career. And
Just a test of your ability?
It was a test of my ability, and basically, all the positioning techniques that you're taught, some of them had to get thrown out the window, because basically I just had to take my fingers and just kind of pinch his areola right onto the plate. So it was quite a fun experience. And then oftentimes, we do have some pretty fun experiences as mammographers. We see a variety of symptoms that patients come in, but they also share wonderful stories with us as well. And some of these stories can be so uplifting. They've gotten, messages through, their family members, going through certain kinds of treatment. They've encouraged their sisters, their mothers, and, they're doing all, the charity things to bring awareness and hope back into the organization. And as a mammographer, oftentimes we feel a great appreciation from our patients. We really want to be there for them. And whether it's in joy or whether it's in tears, we can offer all the empathy. We offer the hugs. We've cried with our patients, and we've just shared so many joys. And there's wonderful stories out there, and I'm still so looking forward to meeting so many more women and enjoying those different, unique opportunities.
Well, I remember the day when I was told that I had possibly had breast cancer, that a lump was found on me that was very suspicious. And I remember being so cocky about it, because there's no breast cancer in my family. So I went in there and they were taking so many pictures, I kept thinking, what are they doing? And after being in there for about an hour and a half, I was told the doctor wanted to speak to me. And of course, I was petrified. I'm like, what does he want to tell me? And when he did tell me what he told me, afterwards I was thinking, is there ever a good way to tell this to a patient? Is there any nice way to tell a patient, look, we found a suspicious lump on your breast that looks like it could be cancer, and we're going to have to do further studies? How would you normally, doctor, tell a patient that you found a lump that needs further investigation, that they possibly have what looks like breast cancer?
Well, I mean, the main goal is to give them the information, because a patient will always sense if you're stepping around a subject. I mean, there's no way to hide what's going on. I mean, it's not like the older Japanese culture where you just wouldn't tell the patient. I mean, you know, in our society, we want to tell them as much information as possible. Now, in truth, I'll often tell them as much as we truly know, which is if there's an abnormal area in the breast that we want to investigate further with a biopsy, I will say that, you know, there's an area that I'll say often that either looks different than surrounding tissue, or there's a mass here that we'll need to do a biopsy. I actually will almost never say, I think this is cancer, I think this could be cancer. In truth, the implication is always, it's possible that it's cancer, and I will give, if it's truthful, I will say that, you know, there's a possibility this could be a benign mass, such as a fibroadenoma or something else. But, you know, there's a possibility that this, you know, could be something more concerning, you know, like cancer, and that's why we're doing the biopsy.
Also, you know, to be on the bright side, you know, most of the patients that come in for lumps, you know, statistics will show us that 80% of the symptoms that they have are benign findings. So a patient shouldn't automatically worry if they find something, you know, abnormal that they're not used to feeling, because it doesn't always mean that it's going to be breast cancer.
About 1 in 4 of our biopsies turn out to be cancer, but 75% aren't cancer.
And when the ratio of patients you've seen over the years, how many would you say you have lost to cancer?
Well, you know, for true statistics, I don't know the answer to that.
Oh, you
because,
don't?
You know, there's, once we diagnose the cancer, then they'll go meet with the surgeon and their oncologist. And so it's hard to know, you know, what are the statistics for that. You know, I think nationwide, off the top of my head, I think the stats about like maybe 1 in 30 might die from breast cancer. But so it's a pretty low.
Encouraging.
That's
Yeah.
a positive. That's a
Yes.
very
But-
positive finding.
But again, you know, the whole goal of what we're doing is to try to catch cancers as early as possible. And so if we catch them when they're small, when they're 1 centimeter, or when it's just the calcifications of DCIS in the breast, the statistics for that are great. You know, greater than 90% of those women will, you know, be alive in 5 years. Where if it's a much larger mass, if we're talking, you know, 3 to 5 centimeter mass where there's cells and lymph nodes, then it's about, you know, maybe only 50 or 60% of those women are alive in 5 years.
Wow. Well, since much younger women are developing cancer now, what is the medical community doing to screen these younger patients?
Well, you know, so the earliest recommendation for a woman with an average risk of getting breast cancer is starting at 40. So when you're talking younger women, you know, we're talking maybe 20s and 30s, and women who are in their 20s and 30s can get breast cancer. It's a much lower likelihood, but it can happen. I think the main thing that women can do if you're 20 is really to know what your family history is. You talk about, you know, a lot of women will say, well, I don't have any family history of breast cancer, so I'm not going to get breast cancer. Well, truly, about 85% of women don't have a family history of breast cancer, but there's this 10 to 15% that may have a very high likelihood of getting breast cancer. And so if they are high risk for breast cancer, if you know of 2 close relatives, or even 1 close relative, your mother and sister who had breast cancer before menopause, that may indicate that you might have in your genes a predisposition to getting breast cancer. So if you know that ahead of time, then for screening, we would recommend, if you have a high likelihood of having one of the breast cancer genes, is really just maybe start mammography and MRIs at 25.
Okay.
Now, for women of average risk, there's a main recommendation out there of just, you know, if you're seeing your doctor every 3 years for a breast exam, or just knowing your own body. You know, self-exam is controversial. I think some women do a great job of it, some women don't want to do it at all. I think it's always helpful just to know your body. If there's something different going on, to not ignore it.
Okay. So how do you, she takes the pictures, and I know she takes great pictures because she didn't have to take as many on me as I've had taken in the past. How do you detect the cancer?
So what we're looking for when I'm looking at the pictures here on the mammogram, again, we talked about the calcifications. That can be
Right.
the earliest form of breast cancer.
Okay.
Other things we're looking for are the masses, where now the cancer has gotten outside the duct and it's forming a mass where it's occupying space and enlarging. And so at that point, we're looking for something that's looks different than the texture or the shape of the glandular tissue that we're seeing here.
Okay.
The other thing that often we're looking for is the changes that can happen to the tissue around a mass or around a cancerous process, where it can look like it's pulling on the normal arcs and curves of the tissue, and that's called distortion. And if we see any of those, then what we want to typically do is often we'll do further mammogram pictures highlighting that one area. We may also do an ultrasound, which uses sound waves to look at the breast tissue, and it gives us a different look, and especially for masses in the breast.
Okay.
The mammogram, a cyst or a mass on a mammogram looks the same whiteness, looks the same density. An ultrasound, though, is great at telling us whether it's just fluid inside this or it's a mass. If it's just a fluid-filled cyst, that's a benign thing, so that's great. That's when we can tell a woman right then, this is a benign thing, don't worry about this at all. If it's something solid, then, at that point, based on what else is going on, often we'll want to sample that tissue to see what's going on.
Okay. Thank you. You've been so informative. Jenna, we're running out of time. Is there anything you want our viewers to know from a mammographer's perspective that will help them before they come in to see you?
I just want to encourage women out there to come in for their routine mammograms. I want them not to be afraid. Do not think of the mammographer as a contortionist. We oftentimes get a bad reputation for that. We're actually very caring. We want you to come in. We know that mammography and early detection saves lives. It affects all of us at some point. And the exam, it's not, most people think of it as such a painful exam. And I think it's the fear of the pain rather than the pain that gets them. So just come on in, let us know how we can, make this easier for you. It's very quick. Compression takes just a few seconds.
Great. Thank you. What about you, doctor? Anything you want to leave with our viewers before we go?
I would say well, to echo what Janice says, the most important thing is to get your screening mammogram. I mean, it's proven to save lives. And the controversial ages of 40 to 50, I think there's about 30 to 40% reduction in deaths from breast cancer in that age group.
I want to thank you both and everyone who's helped me to produce this show today, and encourage people out there who are finding anything suspicious to listen to what's been shared here and call and schedule your appointments. So thanks for joining us. Hopefully we've been able to provide information that will help you and put to rest any fears you may have. So pick up the phone and schedule your appointments. The one place you should not call to schedule an appointment is at this clinic. Thank you so much again for joining us, and hopefully you will take what the doctor has to say and bury your fears, and if it's that time in your life, schedule your appointments. Thank you very much.